Welcome to Breaking Down Mental Health with Dr. Jones. In these educational videos, Dr. Jones will discuss mental health diagnosis, clinical supervision, using technology in counseling, multiculturalism, and many other topics to help you get a healthy understanding of why mental health is important. Please don't forget to like, subscribe, and hit the notification button if you enjoy these videos.
This deep dive was created using generative AI tools to support accessibility and clarity. The content is grounded in the research and instructional work of Dr. Michael Jones. Welcome to the deep dive. Okay, picture this. You're a mental health professional, right? And your client, maybe hundreds of miles away, is suddenly in crisis. You can hear the fear in their voice. It's really palpable, but you can't actually be there. You can't see their surroundings. So how do you handle that? How do you ensure their safety? Today, we're taking a deep dive into exactly that, crisis management and ethical decision-making in telemental health settings. And this isn't just, abstract theory. If you're working in virtual care or even just thinking about it, this is really essential stuff.
It really is. It's such a critical moment for our field, I think. Technology, well, it's opened up incredible access, hasn't it? Breaking down those geographic barriers. But that accessibility also brings these unique complexities, especially when a client is in real distress. We're essentially talking about adapting our core therapeutic skills to a whole new environment, an environment where the usual rules, for safety, engagement, even legal jurisdiction, they're all shifting. The stakes are just incredibly high. And understanding these nuances, it's absolutely vital for competent practice today.
Absolutely. So our goal today is to kind of unpack the key terms first, then identify the core risks that are unique to virtual care. We'll explore the ethical frameworks guiding decisions, and then, really importantly, talk about the practical adaptations needed. How do we navigate crises safely and ethically in this virtual world? Let's maybe start by laying some groundwork, getting on the same page with concepts. It's important, I think, to acknowledge up front. While telemental health has exploded, there's still research going on. Like Lohani and colleagues in 2024, they highlighted that the evidence isn't fully conclusive yet on its effectiveness specifically for reducing suicidality. What that really tells us is that the way we deliver care matters. It emphasizes why these specialized protocols for virtual crisis are just so critical.
That's a really great point. It highlights the unique vulnerabilities we're navigating. And to really get a handle on this, we need to be clear on some core terms. First up, crisis intervention protocol. You can think of these as your pre-planned, structured procedures, specifically designed for mental health emergencies, but in a telehealth setting. They're your roadmap, really, when every second counts.
Okay, a specific telehealth roadmap. Makes sense.
Then there's informed consent for telehealth. And this isn't just, getting a signature. It's a really vital, transparent conversation. It's where you have to disclose all the unique aspects of doing therapy virtually. Things like technology limits, jurisdictional issues, and critically, your specific crisis protocols and emergency procedures that apply because it's virtual care. It's about setting clear, honest expectations right from the start. The NBCC, the National Board for Certified Counselors, they really emphasize this comprehensive disclosure and robust emergency planning in their standards. It's a cornerstone.
So it's about making sure clients really understand the unique landscape, the virtual terrain they're entering.
Okay, that makes perfect sense. But what about actually assessing risk? When you can't physically be there with someone, how does that work differently?
Yeah, that brings us right to virtual risk assessment. This is the process, obviously, of evaluating a client's safety, maybe suicidal ideation, through the telehealth platform. But the key thing to grasp here is its inherent limitations compared to being in the same room. You just can't observe subtle environmental cues in the same way.
Yeah.
What's immediately around them. Or fully conduct what we call a means assessment, understanding what tools for self-harm might be right there, easily available. That visual gap means we have to rely much more heavily on direct questions, on the client's self-report, and that can be challenging during a crisis.
Right, you're missing a whole layer of information. Exactly. And alongside that, we have the Safety Planning Intervention, or SPI. This is an evidence-based suicide prevention strategy, but it's been adapted for telehealth. It involves working collaboratively with the client, developing a personalized plan for how to respond in a crisis. And the really powerful thing here, the potential takeaway, is that virtual SPI might offer enhanced scalability and accessibility. We can potentially reach more people with these critical life-saving plans, which is incredibly promising.
Okay, so we have the basic language down: crisis protocols, informed consent, virtual risk assessment, safety planning. Now, here's where it gets, I think, really complex. the specific challenges that make virtual crisis work so different from in-person. Gilmore and Ward-Ciesielski, back in 2019, they identified 3 critical risk areas, things every virtual provider really needs to understand deeply.
They did. And these 3 areas really capture the tightrope we walk in virtual care. The first one is limitations in assessment capabilities, like we touched on, right? In a virtual setting, your ability as a clinician to observe subtle body language, see those environmental cues, or really assess for means of self-harm, it's significantly impacted. You just can't see the whole picture, literally. You might miss nonverbal distress cues you'd normally pick up on. So the practical takeaway here is that we have to actively compensate. We need to rely more on direct, maybe more pointed questioning, and much more collaborative safety planning with the client. It demands a different kind of clinical vigilance, really.
So it's not just doing the same assessment, but remotely. We're actually developing new assessment muscles for this context.
Yeah.
What's the second risk area?
The second is the lack of control over the client's environment. Think about it. In an office, you control the space, ensure privacy, manage distractions, maybe even have an emergency response plan tied to that physical location, but virtually.
Yeah.
The provider has to operate within whatever location the client chooses, their home, maybe their car, a public library, anywhere.
Right.
The critical implication there is that proactive safety planning isn't just, a nice to have. It's absolutely non-negotiable. Your plan has to anticipate potential environmental factors. You need clear protocols for assessing environmental safety, even from afar. Since you can't control the space, you absolutely have to control your plan for dealing with the space.
That's a huge difference.
Yep.
And the third risk, I'm guessing it relates to getting help quickly if someone is in immediate danger?
You're spot on. The third risk is limitations in triage of client care. When you're working virtually, especially across state lines, you can face significant delays in connecting clients with local emergency services. You might not have that immediate familiarity with resources in the client's specific geographic area, particularly if they're in a different state or even just a different county you don't usually work with. This really demands comprehensive preparation. Things like maybe pre-established contacts with crisis services in areas you serve often, detailed knowledge of emergency procedures across all the relevant jurisdictions. The crucial insight is your response time could be inherently slower just due to the distance and unfamiliarity, so your preparation has to be even faster, even more thorough to compensate.
So if I'm hearing this right, the common thread across all 3 risks seems to be control and visibility. We're often operating with less of both in the virtual space. And when you connect that back to the bigger picture, these risks really highlight the importance of our ethical codes, like the ACA Code of Ethics, particularly the part about our primary responsibility being client welfare.
And addressing serious foreseeable harm, we have to figure out how to actually do that within these virtual constraints. And the NBCC Code of Ethics, the 2023 version especially, gives critical guidance too, right? Emphasizing those robust emergency procedures, careful client screening for telehealth appropriateness, and the absolute need for legal compliance across different jurisdictions.
Absolutely. And what's fascinating, I think, is how these risks force us to develop almost a new layer of ethical decision-making frameworks. Specifically for these complex virtual scenarios, we're not just applying the old models. These frameworks now have to explicitly integrate things like technology variables, navigate those tricky jurisdictional complexities, and account for how the therapeutic relationship itself changes in virtual care. The key insight, maybe, is that virtual care isn't just a different delivery method. It fundamentally reshapes the ethical landscape. It demands we reevaluate our most basic principles, even down to how we gather information for informed decision-making when, tech limitations might actually affect the quality or completeness of the clinical data you're getting. Wow. And that complexity leads us right into another vital ethical consideration. How do we ensure cultural responsiveness when dealing with a crisis virtually?
Well, absolutely. Cultural barriers can definitely be amplified in a virtual setting, particularly when clients are highly distressed. Imagine a client who usually communicates comfortably in English, but under extreme stress, they might revert to their primary language, or maybe express distress in ways that are very specific to their cultural background. This demands culturally responsive intervention strategies that account for the virtual context. Things like just basic technology access or digital literacy levels, even pre-existing cultural attitudes towards interacting virtually. These can all influence the therapeutic process in profound ways.
So it's more than just language.
Much more. It means the ACA's guidance on culturally inclusive treatment planning really needs careful adaptation for these virtual-specific cultural dynamics. And the NDCC, in their standards, they explicitly emphasize cultural responsiveness extending to these technology-mediated relationships. We have to be mindful of it.
That's a critical point. It's the whole cultural context interacting with the technology.
Mhm.
Okay, so with those ethical considerations laid out, the next major hurdle often comes up when clients, or even we as providers, are in different states. That's where the maze of multi-jurisdictional legal and regulatory considerations really starts.
Yeah, this is genuinely one of the thorniest areas, cross-border practice, providing telemental health when the provider and client are in different jurisdictions. It just creates this whole cascade of legal and ethical questions. We're talking licensure, duty to warn obligations, coordinating emergency responses across state lines. It gets complicated fast. Richmond, back in 2022, pointed out how things like the Interstate Medical Licensure Compact, the IMLECC, helped speed up physician licensing across states during the pandemic, which was great. But, and this is the key thing, even with that, there are still significant variations in crisis intervention requirements, emergency commitment procedures. They still exist across jurisdictions. The critical takeaway is that faster licensure doesn't equal unified laws. Not at all.
So even if getting the license is easier, the actual rules you have to follow can still be completely different depending on where your client is.
What about duty to warn? That's always a big one, and it sounds like it could be even trickier virtually.
Oh, it is. Duty to warn obligations are particularly complex in virtual settings. Lambert and Wertheimer, for instance, they note how much these laws vary state by state. Some states mandate disclosure if there's a threat. Others only permit it. Some offer very little clear guidance. Think of it like this. You're driving, right? The speed limit changes when you cross a state line. With duty to warn, the rules for when and how you might need to breach confidentiality can change just as drastically. It depends on where you are and where your client is. The really crucial insight for providers is you absolutely must understand the legal requirements in both your practice location and the client's location. Because which jurisdiction's laws apply can depend on various factors like where the threatened person lives or even where the harm is predicted to occur. It's definitely not one size fits all. Wow, that sounds like a significant amount of legal homework and just ongoing vigilance required from providers. And how does this multi-state reality affect something as basic as documentation?
Well, even documentation requirements get more intricate. Your notes have to meet the legal standards of potentially multiple jurisdictions, and they also need to capture the unique aspects of virtual care, like documenting the limitations of your virtual assessment, noting any technology factors that influenced your clinical decisions, and recording all the coordination efforts with emergency services, especially if they cross state lines. The NBCC standards on record keeping and client information stress thorough, accurate documentation. But now there are these added layers of jurisdictional complexity. The key isn't just what you document, but ensuring it satisfies the legal demands of where everyone involved is located.
Okay, so we've talked about the unique risks, the ethical layers, the legal complexities. It's a lot. What does this actually mean for day-to-day practice? How do we adapt our strategies to manage all this effectively in the virtual space?
Right. That brings us to the practical side. Safety planning adaptations for virtual environments. Now, while the evidence specifically for reducing suicidality via telehealth might still be developing, Lohani and colleagues did find that safety planning delivered virtually offers real potential for enhanced scalability and accessibility. That's important. So when we're working with a client to identify warning signs, coping strategies, support resources, we have to deeply consider the virtual context in that collaboration. That includes things like the client's actual technology access, privacy concerns in their home or wherever they are, and the precise availability of local crisis resources specific to their physical location, not just generally, but where they are.
Right, tailored to their exact situation.
Precisely. And crucially, the safety plan itself needs to explicitly address what happens if the technology fails. It should include multiple ways to communicate, multiple pathways to ensure you can maintain support, even if your main video platform crashes. And trying to integrate family or other support persons or local crisis resources, that gets much more complex when different jurisdictions are involved. It requires really careful navigation of confidentiality, privacy rules, and just the logistics of geography. The practical takeaway is building a safety plan that's resilient to the specific challenges of the virtual world.
It really sounds like having a solid backup plan for the technology itself is just as critical as the therapeutic content of the safety plan. We've all had that frustrating experience of video call freezing, right? But imagine that happening when someone's in deep distress. It's not just annoying, it could be terrifying for everyone involved.
Absolutely terrifying. And that leads directly into technology considerations and backup protocols. Technology failure during a crisis isn't just possible, it's a distinct risk we have to plan for. It demands proactive planning and immediate response capabilities. The NBCC, in its standards, is very clear. Counselors need written procedures for emergency assistance, including alternative ways to deliver services if the primary tech fails. It's this constant balancing act, isn't it? Between secure communication, which is vital for confidentiality, and the urgent need for immediate crisis response if those secure platforms suddenly aren't working. Your crisis protocols need sort of a hierarchy of communication options, prioritizing client safety above all, while still maintaining appropriate security whenever feasible. And these protocols, they absolutely have to be clearly communicated during informed consent and easy for you to access during a crisis.
And it seems like this planning really needs to start right at the beginning of the therapeutic relationship, doesn't it?
Yeah, it really does. Assessing a client's technology access and their digital literacy during that initial contact is just crucial for effective crisis planning later on. The NBCC requires counselors to provide detailed written descriptions of the whole telemental health process, including equipment needed, confidentiality limitations. So as providers, we need to understand the client's devices, their internet reliability, how familiar they are with backup communication methods like phone calls or specific apps, and any limitations they face that might impact communication during a crisis. That initial assessment should then inform not just ongoing treatment planning, but the specific crisis protocols tailored to that client's tech situation. The key is building that tech-informed safety net right from day one.
This brings up a really important question, I think. With all this added complexity, the tech, the laws, the assessment limits, what does this mean for our own professional development and competency? It sounds like we need some pretty specialized training, not just on using the platforms, but on these fundamental shifts in how we practice.
We absolutely do. Virtual crisis management demands specialized competency development. It goes way beyond traditional crisis intervention training. The Council for Accreditation of Counseling and Related Educational Programs, or CAFREP, pronounced KCREP, they've actually revised their 2024 standards to specifically emphasize integrating technology competencies with core clinical skills.
Ah, okay, so it's built into the standards now.
Yes. It means really understanding the modified therapeutic relationship dynamics in virtual settings, recognizing the inherent limitations of technology-mediated assessment, and knowing how to navigate those multi-jurisdictional legal requirements. All of this is reflected in various NBCC standards, too. The main point is this isn't just some optional add-on skill anymore. It's becoming a fundamental part of competent practice, demanding a new kind of expertise.
That makes sense.
And because it's so complex, consultation becomes even more critical in virtual crisis situations. The mix of technology issues, conflicting state laws, cultural factors, it can easily go beyond any single provider's knowledge base. The ACA Code of Ethics emphasizes consultation, and it's doubly important here. Virtual providers really should proactively build consultation relationships. Find specialists in telehealth ethics, crisis intervention, maybe even lawyers familiar with requirements across the states you work in. And ideally, having immediate consultation available during a crisis should be part of your practice plan. It's also vital we mention self-care protocols for providers.
Yes, definitely.
The unique stressors of doing crisis work this way, that uncertainty from limited observation, the fear of tech failures, the legal worries, it can be incredibly draining. Professional development needs to include strategies for managing these virtual specific stressors, because you simply can't help others effectively if you're burning out from the unique demands of the job.
That's such a critical reminder for the professionals doing this demanding work. Okay, finally, let's talk about connecting all of this planning and protocol with the actual on-the-ground emergency services and local resources. This often feels like the biggest unknown when managing a crisis from a distance.
It really is a crucial link and often the most challenging. Coordinating virtual crisis intervention with local emergency services requires proactive relationship building and really clear communication protocols. It's not something you want to figure out during the emergency. Virtual providers ideally should establish connections with crisis services in the geographic areas they commonly serve. Keep current information about local emergency procedures, resource availability, contact protocols. This prep work is absolutely essential when you need an immediate emergency response for a client who's miles away. That proactive groundwork can literally save lives.
And what about privacy rules like HIPAA during that kind of coordination? especially if multiple agencies or states are involved.
Yeah. HIPAA compliance during emergency coordination definitely presents ongoing challenges, especially when multiple providers and maybe emergency services need to collaborate across jurisdictions. Virtual providers have to understand the rules around information sharing in emergencies, while still being diligent about protecting confidentiality appropriately. The NBCC standards are helpful here. They generally permit sharing client information without written consent when it's necessary to prevent serious and foreseeable harm to the client or others. That provides the ethical foundation for emergency disclosure. But having clear protocols for how emergency information will be shared should be established beforehand and ideally communicated during the informed consent process.
Got it. Preparedness again.
Always. And finally, integrating local cultural resources and community supports into virtual crisis intervention requires ongoing learning. As virtual providers, we might serve clients from communities we have very little personal familiarity with. That means we need adaptive approaches to identifying resources and understanding how the community functions. This cultural responsiveness goes beyond just individual client characteristics. It means understanding local community resources, specific cultural attitudes towards mental health services in that area, and even how the local emergency response systems work within that cultural context. It's about staying informed and connected even when you're physically distant.
This has been incredibly insightful. It really highlights the layers of complexity involved. So, as you, our listener, think about today's deep dive, here are a couple of reflection questions to consider. First, how might the specific limitations we discussed, like those in virtual risk assessment or environmental control, actually show up in your current telemental health practice? And thinking about that, what proactive steps could you take now to mitigate those challenges? And second, considering the multi-jurisdictional complexities, especially around duty to warn and maybe emergency commitment laws, what specific actions might you take to ensure you're compliant and prioritizing client safety when working with clients in different states? And, importantly, how could you integrate this clearly into your informed consent process? Thank you so much for joining us on this deep dive into crisis management and ethical decision-making in telemental health settings. We really encourage you to continue learning and reflecting on this critical, rapidly evolving area of practice.